Bismillahirrahmanirrahim. Assalamu alaikum students. I hope all of you are fine. We are here with a very important topic, that is pharmacogenetics, which is an emerging area of clinical medicine focused on understanding how genes affect individual response to treatment to a particular drug. So in other words, it can be defined as it's a branch of pharmacology that is dedicated to study of genetic factors in the response to a particular drug. In easy words, if I elaborate it further, for example, in a study conducted in a population, for example, in this classroom of third year MBBS, we give a particular drug, same drug to all the individuals. All right. And what happens next? The response to that drug is different in each and every individual. In some individuals, there is going to be a very good predicted response, whereas in some individuals, there is no response. So how the response to a particular drug is different in each and every individual. So what is the main reason for that? Of course, we all know that. Think about it. Yes, it's the work of genetics. Since each and every individual has its own genetic makeup, so that is why the response to that particular drug in an individual is going to vary amongst their fellow colleagues. All right. As this is self-explanatory, so we are all different. So the response to the drug would be different in all of us. If we see this diagram, we can easily well appreciate that in some individual, what is happening, that the standard dose, whereas in some other individual, the lower dose can produce the beneficial effect, whereas in other individual, the higher dose of a drug is going to be best for that particular individual. So why the response is different in different individuals? Some have to take a higher dose to get the same response. Some have to take a very low dose and they get the same response. The reason is there is different in the genetic makeup of each and every individual. And for that particular reason, we do a genetic testing. All right. We label it as full response, or we can say as good responders, partial response, or we can say it's submaximal response, and non-responsive means a poor responder as well, or a non-responder. And in some individual, the drug may show its severe adverse effects, but it is very rare, as you can well appreciate. So the different in the response to a drug in different individual is varied because of the genetic differences, and this comes under the heading of the study of pharmacogenetics. So what is the goal of pharmacogenetics? It is what we have to achieve. We have to give the right drug, right dose for the first time, not the hit and trial method of prescribing a drug. For example, if we give this drug in a particular individual, so it is going to get a benefit. But if we keep on giving, we keep on increasing the dose of that drug, but the response is not seen. So what is going to happen? We are going to go through a lot of hit and trial method, and the person is going to even have adverse effect of that particular drug, but not the beneficial effect. So to omit this hit and trial method, what we are going to do, we all know that if 2 million people are hospitalized every year, 100,000 deaths occur, but not now. So we have to fix this. And how we can fix it? With the help of the study of pharmaco. You all know that there is a drug metabolizing system in our body, and the liver is the main site of action where the metabolism of various drugs occur. So we label the few individuals as poor metabolizers, or the good metabolizers, or rapid metabolizers. So if a drug is poorly metabolized in an individual, so what's going to be the consequences? It is going to last longer in the body since it is not metabolized. So when it stays longer in the body, of course, it is going to have more adverse effects, and there is going to be more accidental overdosages and injuries. Whereas in some individuals, the metabolism is ultra rapid. All right. So what is going to happen? The drug is going to be metabolized in a wink. So what is going to happen that the drug's efficacy is going to be decreased since all the drug is going to metabolize before its effect is shown. So this variety of metabolism system is called good metabolizers, poor metabolizers, or good responders or poor responders. So what are the benefits of pharmacogenetic studies? Of course, they can give more information and lead to the better outcomes of the patients. The variation in the drug response is affected by a number of factors: gender, body mass, age, environmental agents, disease, genetic factors, diet, and co-medication. You have been delivered a very detailed lecture on the factors affecting the drug of the dose. So this is all the summary of these factors. Genetic factors can be a racial difference, age, sex, liver size, body temperature, drug metabolism, and drug elimination. All these factors affect the response of that particular drug in an individual. There are also some non-genetic variables which affect the response to a drug. That can be nutritional status, environmental factors, enzyme inducers, and enzyme inhibitors. So what is the clinical significance of pharmacogenetics? The most important thing, which is that we can see the unusual dangerous response to a drug. All right, if the drug is not metabolized and we are giving the drug and it gets accumulated in the body because of its defective metabolizing enzyme system, so it may lead to severe adverse effects. Let us have some examples of the drugs which come under the heading of pharmacogenetics. For example, if in an individual there is genetic defect in the oxidative enzyme system, and you all know that oxidation reaction is a phase 1 reaction of biotransformation. So what happens that it occurs in 3 to 10% of Caucasians and white. This is how the race affects the response to a drug, because we have seen that it is transmitted as autosomal recessive trait in a particular drug, that is diprisoquine. So this is a polymorphism of oxidation. And there is impaired cytochrome 2T6 dependent oxidation. So in that person or in that patient who is taken this drug, there would be defective oxidation, and that is why the drug would not be metabolized and they would stay in the body for a longer period of time, leading to its adverse effects. And this is seen mostly in the Caucasians and whites. So the problem is with the cytochrome P450 protein system, where is the faulty expression. There may be a polymorphism of that particular cytochrome enzyme system, and leading to the toxicity of that drug. So how we can predict diprisoquine? If we plot this log dose and response of the drug. So as you can see, few individuals, they are rapid metabolizers of this drug, whereas some individuals are extensive metabolizers of this drug and some are poor metabolizers. Then we have nortriptyline. It's an antidepressant. It has got a metabolism in some individuals which is ultra rapid metabolism, where there is defect in the cytochrome 2D6 allelic variant. So it is seen mostly in Ethiopians and Saudi Arabians. So this is how the race affects the metabolism of the particular drug. And there is threefold higher doses of nortriptyline is needed. So remember students, at this point, those individuals in which the drug is metabolized rapidly, you need to give a higher dose. And those individuals the drug is metabolized slowly, you need to give a low dose, because If you give a higher dose, what is going to happen? The drug is already not metabolized, so it is going to stay in the body for a longer period of time, leading to increased plasma half-life and leading to its adverse effects. Whereas if you give a normal therapeutic dose of a drug in those individuals where there is a mutation in a particular gene system, so the drug is going to be metabolized very rapidly. So all the drug is going to be metabolized and its clinical effect is not going to be shown. So you need to increase the dose of a drug in these type of individuals. Then we have an example of codeine. Codeine is basically an opioid analgesic, and it has its clinical use as a cough suppressant as well. So it's a prodrug and it is metabolized in the body to morphine and leading to its increased level. We have mefenitoin, which is anticonvulsant, which is used for the treatment of epilepsy. So what is happening if an individual has a defect in the cytochrome 2C19 enzyme system? So what is going to happen? There is going to be a defective metabolism of that drug, and that is seen particularly in Caucasians and Japanese individuals. In normal extensive metabolizers, two enantiomers are seen, like S-mefenitoin. It is extensively hydroxylated to excretion, while there is another enantiomer of this drug, which is R-mefenitoin, which is slowly metabolized and demethylated to an active metaboloid, which is nervinol. So these are its two variations, which is seen as rapid metabolizers and slow metabolizers. All right. And poor metabolizers, they lack the S-mefenitoin hydroxylase activity. So both enantiomers are demethylated to its active nervinol, thus showing signs of profound sedation and ataxia. Phenytoin basically is an anti-epileptic drug, and when it is given, it shows some adverse effects, and one of its adverse effects is on the CNS, that is profound sedation and ataxia, and that is because of its um, active metabolite, which is the nervinol. So what is happening? Both the enantiomers are converted into its active metabolite, and they show signs of CNS toxicity in which there is excessive sedation and ataxia. All right. Then warfarin, which is an oral anticoagulant drug, and it is metabolized to the cytochrome metabolizing system 2C9. So in some individual, there is a mutant allele of this particular enzyme system, which leads to decreased enzyme affinity for warfarin and decreased clearance. So when warfarin is not metabolized and not cleared from the body, there would be more drug levels of the warfarin in the body, which leads to its toxic effects. So there would be bleeding and hemorrhage. Then there is another case of warfarin resistance that it differs from the cytochrome metabolizing defect. That is a resistance to warfarin. It is hereditary resistance to the drug. And what happens that there is inactive vitamin K epoxide catalyzed to active hydroquinone form. So when you'll be discussing about the anticoagulants in the chapter of blood, then you will study in detail the mechanism of action of warfarin. Then you would understand that there is vitamin K is required for the activation of the some clotting factors, that is 2, 7, 9, 10. So warfarin basically inhibits this vitamin K dependent clotting factors, and vitamin K epoxide is required. So when there is resistance to warfarin, what is the reason? There may be inactive vitamin K epoxide and the drug is not showing its effect. You are giving the dose of the drug as an anticoagulant, but the effect is not shown. Why? There may be the reason of warfarin resistance. And warfarin binds with the enzyme warfarin vitamin K epoxide to inhibit the hydroquinone form and leading to resistance. Mutational change can occur in vitamin K epoxide reductase enzyme, which leads to the malfunctioning of warfarin. Now there's a very interesting example of pharmacogenetics in which there is isoniazid. This is a drug which is used for the treatment of tuberculosis, which is called TB. So in some individual, this drug is metabolized rapidly and these individuals are called fast acetylators, and this trait is dominant and more metabolites are formed in this case. And slow acetylators are less metabolism and more of the parent drug form is present in this case. So autosomal recessive, 50% blacks and whites in Europe and America, and less common in Asians and Eskimos. So what you have to remember, in isoniazid, there are two types of variations. Some individuals are metabolizing the drug very fast and some are metabolizing it slowly. And how they are metabolizing it through the acetylation process, which is a phase 2 reaction of biotransformation. So this is autosomal recessive carried in the other individuals, and it is seen more in the blacks and whites in Europe and America. All right. Half-life of the drug may become about less than 2 hours, which was actually 2 hours. It becomes 1.2 hours in rapid acetylators, while in slow acetylators, the half-life is going to increase. So if the drug is metabolized slowly, of course, there are going to be slow elimination, so the half-life is going to be increased. Fast acetylators. What is the consequences of fast acetylators? There is more hepatic toxicity. Why there is more hepatic toxicity? Because there is a more rapid toxic metabolite formed of isoniazid. All right. So this is a very important question which can be asked in exam in journal pharmacology, here as well in when you do the chemotherapy, when we're discussing in detail about the antituberculous drug, the side effect of isoniazids are very important, and you can be asked, for example, that in some individual the drug is rapidly metabolized. So what is the consequence of that drug? So if you know that in the fast metabolizer there is more formation of toxic metabolite and the efficacy of the drug is going to be decreased. Why? Because the drug is going to be metabolized at a faster rate, and hence it will stay in the body would be for a short period of time, but it can lead to hepatic toxicity. Whereas in slow acetylators there is another toxic effect seen, which is peripheral neuropathy. All right, and it is due to because of the parent form. In the fast acetylators, the hepatic toxicity was seen because of its toxic metabolite, whereas in slow acetylators, peripheral neuropathy, which is a side effect of isoniazid, it is because of its parent drug, not the metabolite. All right. In peripheral neuropathy, the patient presents with numbness and tingling, and this is a classical scenario which is given to you in exam. That a patient who was taken anti-tubercular drug therapy, and 3 weeks after its treatment, he developed numbness and tingling in the its peripheral limbs. So what is the most likely drug? So of course, amongst the five first-line anti-tubercular drugs, isoniazid is the only one which causes peripheral neuropathy, and that is more seen with individuals who are metabolizing the drug at a slower rate in the slow acetylators. So you need to remember this from the SCQ point of view as well as from the MCQ point of view. And MCQ, you can be easily asked that in slow acetylators, what toxic effects would be seen? So it is peripheral neuropathy, whereas in fast acetylators, what it was effective seen? Hepatic toxicity. All right. So this is a pharmacokinetic variation of isoniazid. It is metabolized through transferases, N-acetyl transferase, and leads to fast acetylators and slow acetylators. And fast acetylators lead to hepatotoxicity, whereas slow acetylators leads to peripheral neuropathy. So this is a very, very important short essay question, a viva question, and an important MCQ. Thank you very much, students, for your patience and for being with me. For your assignment for today's lecture, kindly submit on the WhatsApp group. From your textbook, there is a separate whole chapter on pharmacogenetics and genomics, in which write down example of how the response of hydralazine differs in different individuals. You have to write a short note in your own words, go through hydralazine that would be mentioned in this chapter, as well as in see the index, and there would be hydrolazine in the chapter of cardiovascular system as an antihypertensive. So I'm telling you a little bit about hydrolazine. Hydrolazine is an antihypertensive drug, which means it is given for the treatment of high blood pressure. So in some individual the response is different, and in some individual the response of hydrolazine is different. So you need to find out why hydrolazine has a different response in different individual, and submit it on your respective WhatsApp groups. And with that, I would like to add on one more thing, that there was a very poor participation of you people from the tutorial. So kindly get more of an interactive session, because this is going to help you more, because we are not interacting with you people like we should interact with you in the live lectures, because unfortunately because of this situation. So you need to stay with us, interact with us. It's for your own betterment. Otherwise pharmacology is a very um, difficult subject in terms of memorizing the names of the drug again and again and again. So that is why we are um, asking you for the vivas and tutorials and written test, because you need reinforcement. All right. So I know you are with Rosa and everything, but you need to memorize. I'm teaching you this topic in small chunks. So I'll be covering the another part 2 of the pharmacogenetics tomorrow. Just go through the chapter of pharmacogenetics in your mini catchings. I hope all of you have got your books. If you have not got your books, please buy your books, Lippincott and Katzing Review, and go through this chapter. This is a very important chapter, since I told you this is an emerging topic, pharmacogenetics, and many questions are being asked from exam in general pharmacology as well as from systemic pharmacology. Thank you very much. Allah Hafiz.